Dr. LaHood graduated from Rush Medical College and completed her family medicine residency, followed by a fellowship in maternal child health. Following her training, she spent 5 years working at a community health center in Indianapolis and then joined the St. Vincent's Family Medicine faculty in 2005. She has a passion for population and public health and has served as a volunteer member of the Indiana Attorney General's Drug Abuse Prevention Task Force since 2012. In addition to teaching residents, Dr. LaHood continues working throughout Indiana to educate physicians about the benefits and risks of treating patients with opioids. Earlier this year, Dr. LaHood made public comments before SAMHSA and the FDA in Washington, D.C. to advocate for decreasing barriers to integration of substance use treatments and to encourage the FDA to increase transparency to providers regarding the evidence for opioids. And she's going to be speaking to us today on responsible pain management, prescribing opioids in your practice. And again, this is one of the 2 lectures that will fulfill your opioid CME requirement for Indiana.
Thank you. Yeah, thank you. Happy to be here. We're going to talk a little bit about opioids and hopefully give you guys some tools that you can use in your practice. In addition to that, this will satisfy that requirement so that when you apply for your CSR and your license renewal in next summer, you will need to have some kind of evidence that you've done 2 hours of opioid-related CME. So this will satisfy that. So that may be another reason why you're all here today. I don't have any financial disclosures to speak of. I want to start and just give you a little bit. I have a lot of information to talk about, and I'm hoping that this will parallel with our next speaker, which is Dr. Mackay. So I'm a family doctor, like Teresa said, so just like all of you. And then our next speaker is a pain specialist. So hopefully you'll get a little bit of balance there and 2 different perspectives in how we can better treat patients that have pain and better understand how we can effectively use some of the medications to treat patients. So we're 4.5% of the world's population, yet it's astounding that we consume, and this is published in 2018, but it's 2016 year-end data, of world narcotic production and consumption. So we still consume 99.1% of global hydrocodone. We consume 73% of the oxy products. And a low estimate is that we consume 2/3 of global illicits. So the backdrop of this issue, and I don't think I need to tell any of you this because you see it every single day in your practices, we live in a world where there is an insatiable appetite for mood and mind-altering drugs. So that is a request that we get all the time, and that's just part of the culture that we live in. So that's a really tough thing for us to kind of counter when we are trying to help our patients, is that there's a demand for this. Most of you also may remember there was a really big change in the way we treated pain. So when you look between 97 and 2007, you guys see a lot of studies, you see a lot of data, and within a 10-year time period in this country, we increased the per capita morphine opioid use by over 400%. So that's crazy because we all know that, you just don't see changes like that very often in medicine. So there was a lot of reasons why this change in paradigm of pain treatment happened. And one of the reasons is we're definitely seeing more people with chronic pain. Some people say that there is an epidemic of chronic pain. The traditional definition is pain that lasts longer than 3 months, but there's a lot of definitions that people are now using because we're talking a lot more about pain. So a lot of times now we're saying that it's pain that persists beyond what would be expected given the degree of pathology. So the prevalence of chronic pain is really high. It's estimated that about 1 in 4 persons that walk into an ED or even into a primary care office has some sort of pain. We're caring for an aging population. We're caring for a population with an increasing burden of chronic illness. So that all contributes to more patients with pain. There's also an expectation among patients that we have something to treat their pain. So patients come in, and at one time there was kind of a pain bill of rights where patients were, had this expectation that we would treat their pain. There was a liberalization of the laws for opioids in the past, and there was also the Joint Commission Standard, which is like the notorious fifth vital sign that we all know and bristle at the sight of it. So this definitely in my opinion, contributed to the place that we've gotten ourselves over the past 5 years. JCO has completely kind of rescinded this fifth vital sign concept, and they now have a pain standard that's 180 degrees different from what it looked like 10 years ago. So that's good. I guess they kind of got the message, but they never have accepted any responsibility. So I don't like that. And then there was the HCAHPS questions. So these are the questions that every patient is asked across the country when they're discharged from a hospital. And hospitals care a lot about how well they score on HCAHPS because it's directly linked in some way to compensation of Medicare rates. So these are really important. So there was 2 questions that were the most horribly written questions that were on there up until about 18 months ago. So 18 months ago, Congress passed a law that delinked the pain domain from any reimbursement. So that's great. Pain questions are no longer linked to any kind of reimbursement. So that's a step forward in our efforts to provide better pain care. And then the last thing is they have also been reworded. So they're more consistent with what we believe is helpful for patient care at this point as well. But then there was really aggressive marketing on the part of the pharmaceutical company. When OxyContin was put on the market in 1995, there was not one single peer-reviewed study that said the long-acting version of oxycodone was any better than the regular oxycodone, okay? There wasn't a single study. But they were genius marketers, and they went on a bonanza and did over 20,000 educational seminars for providers and physicians and healthcare folks that were touting how this could be used for all kinds of pain. Very quickly, it was realized that this drug was being widely abused. And in the year, on their package insert that came with the drug, as well as at these seminars, they educated everyone that the risk of addiction was less than 1% for this drug. So fast forward to now, and it's like laughable. But in 2007, the FDA fined Purdue Pharma, which is the sole company that produced OxyContin, the largest ever FDA fine of $634 million for that fraudulent mismarketing of the risk of addiction. That same year, their profit was $3 billion. So to a lot of people, they say that's just the cost of doing business in the pharmaceutical industry. So that's not something we can walk back on. The other thing that I'll mention is it's interesting because the FDA has changed their label for all long-acting opioids, but to this day, there still is not a single peer-reviewed study that shows long-acting opioids ever are clinically superior to short-acting. So there may be reasons for us, from a practical perspective, to switch someone from short-acting drugs, opioids, to a long-acting. But let's be clear, there is no evidence to support a clinical benefit to doing that. And long-acting opioids increase all-cause mortality. So I think we should be more reluctant to do that unless we have a really good reason from a practical perspective to increase, to switch over from short to long-acting. The other thing that I'll just share is that the current package insert for OxyContin, it's 39 pages. You can look it up online. There's one single study that shows a benefit. It lasted 14 days, and they only looked at one outcome, pain. So in the 10, when they did the 10 milligrams of oxy compared to placebo, there was no statistically significant change in pain. When they used the 20, there was a statistically significant reduction in pain. It lasted 14 days. So essentially, this is what we have. This is what we're using. The most profitable drug in world history. And there's essentially no evidence to show that it clinically helps people. So I think that should give us pause and help us just understand that, I think all of us have prescribed this drug, or maybe a lot of us, I should say, but we just don't have evidence to support safety or efficacy of long-acting opioids. So I think we should just be cautious that we have a really good reason when we need to use them. And let me be clear, too, opioids are an incredibly important tool in our toolbox. I want everyone here to feel comfortable using opioids when a patient needs them. But I also think we need to be more discriminate and deliberate and thoughtful when we do use opioids, that we're giving them to the right person, and we're monitoring them to make sure they're not one of the people that ends up with an overdose, a death, or some other adverse consequence. The opioid overuse issue has caused us a lot of pain in this country. If you've opened a newspaper or turned on the TV, you can't help but seeing it because it's everywhere. The biggest cost is related to lost productivity, and that's because in large part the persons that are dying from opioid overdose are people kind of in their, what should be in their most productive time of their life. So lost productivity is kind of the red. That's the biggest chunk of the effect on our economy. Then there's a slice for healthcare costs, criminal justice, family services, and education. And it's really scary because you can see the projected increase in the cost really goes up exponentially. The cost to the child welfare system, I'll say, is one of the things that I think is the magnitude of that effect, I think, is incalculable. And I think that's something that we'll continue to learn about. I don't think this story is finished being told because I think it's playing out right now in real life. So I think we'll better understand. But that's really, tragic. And a lot of you maybe know that and have experienced it in your own communities. So in the year 2010, we kind of woke up to the realization that there is a relationship between how we've prescribed opioids and the deaths from opioids and admissions to treatment facilities for opioid use disorder. The thing that probably got governments and stakeholders from public policy folks involved more than anything was when it became more likely that your patient or your family member would die from a drug overdose rather than a car accident. So we've done a lot in this country to make cars safer, right? And we've actually done a really good job because that's the blue line. So, cars now have all these bells and whistles to tell you when to stop and go and make them safer. Seatbelt laws have been really promoted. We've done a lot to decrease drunk driving. So we've done a great job at improving automotive safety, in addition to spending billions on our roads to promote safer driving. But you can see, so when these lines cross, that's really when policymakers decided that they would start getting involved in this issue. And I think that's been, really difficult for us as providers to have lawmakers telling us how to practice medicine. So I think that's been really tough for everyone. So it's estimated today that 1 in 4 persons using chronic opioids struggles with addiction. 115 Americans, which is kind of a low estimate, and it's changing all the time, die every day from an opioid overdose. And in the year 2016, more people died in the U.S. from an opioid overdose than died in the entire Vietnam War. So that's kind of, it's staggering, the statistics of how the harm that this problem has caused to our country. It's affected really every class, every race, and every location in our country. One of the things that I've learned through doing some of this work is that money alone will not solve this problem. This incredible increase in exposure to opioids in this country is something we've got to change. Because the people on this slide, they had seemingly everything to live for. They also had endless money. They had all the rehab money could buy. They had access to the smartest, best medical and rehabilitation facilities, and every one of them died from an opioid overdose in spite of that. So, like I said, I think we still have to focus on decreasing exposure, because once people are exposed, this pathway of opioid use disorder and opioid addiction is something that we just don't have the kind of treatment to cure and to solve for a lot of people. Today, we're struggling because the synthetics, which when I use the word synthetics, it's drugs that are produced in a factory overseas, typically, and shipped here to the United States. So in Indiana today, as well as this kind of mirrors the trend across the country, 2/3 of all the people dying from an overdose are dying from fentanyl derivatives or other synthetics. So that's a tough thing in the healthcare industry, right? We don't intercept with that a lot. That's not something that we maybe directly feel that we can have an influence on. When you look, so this is the number of people that are dying from the synthetics. That's 20,000. There's still a fair number that are dying from straight up heroin. And then here's the natural and semi-synthetics. These are the drugs we're prescribing. there's still about a third of overdose, it's estimated today, are still from prescription drugs. They're either prescriptions that we're writing to a patient we're caring for, or we're writing them for a patient and they end up diverted to another person. So this is really rapidly changing all the time, but the synthetics are a big problem today. One of the things that I'll say about that, though, that I think is still really important is 80% of these persons that are dying from synthetics started their addiction with a prescription pill, either a pill that was written to them or a pill that was written to someone else and taken by a different person. So we are still, in large part, the nidus of a lot of the problems, we in healthcare, that's happening today. We know now that there's a really clear association between persons who misuse or use prescription opioids and then go on to use heroin. So that's something that we've more clearly understood as an unfortunate consequence of this giant kind of study that we've done in giving a lot of people opioids. So one of the things we worry about as we talk about what do we do with a lot of the patients on opioids is we want to make sure that we, as much as possible, don't ever cut people off. Because what we know when that has happened, particularly if practice is shut down and or patients are cut off, is that it's a lot easier to obtain street drugs than it is treatment. And as long as that kind of continues, that it's easier to obtain street drugs than it is treatment, I think that's one of the things that's contributed to more people dying. So we prescribe a lot of opioids. We know there's a lot of harm from opioids. And what we want to know is, are we helping people? So in the year 2014, I think this was a little bit of a watershed moment in understanding how we should approach opioids and chronic pain, because we had so many patients on them. But the American Academy of Neurology, so they're kind of our pain experts, came out with a position statement. And what they said was, where there's evidence for short-term pain relief, there's no substantial evidence of maintenance of pain relief or improved function over long periods of time without incurring a serious risk of overdose, dependence, and addiction. So this was huge, because that's our colleagues telling us, yeah, that's not really a good idea, what you're doing with these millions of people. And then in 2016, the CDC came out with a 50-page document with some guidance on the outpatient prescription of opioids for patients with non-cancer, non-terminal pain. And they essentially said the same thing. They used a little bit different words, but they essentially said the same thing. So I want to share some of the studies that we have. Like I said, we've learned a lot from this kind of experiment that we've done in giving a lot of people opioids over the past 15 years. And now we have a lot of information that really will help guide us in the future about how can we be smarter, how can we do this better. So this study looked at opioid-naive patients, and it looked at their very first opioid script. And it looked at the number of days that first script was for. And on the x-axis, you can see the number of days. So it was either 5 days, 10 days, 15 days, 20 days. Because what we believed for so long, and we didn't have evidence to tell us differently, was that it really doesn't matter if someone gets 2 weeks of an opioid or even 4 weeks of an opioid. They can't get addicted that soon. Or develop, and I shouldn't use the word addiction necessarily, but a dependence or a persistent use. It could be any of those categories. And what this tells us is, it absolutely does matter. Every day matters, because every day longer that a patient gets their first opioid script increases on a continuum the chance that they will be continued on that opioid 1 year and 3 years later. That's the 1 year, and this is the 3 years. So one of the concepts is we always want to give people, when we treat patients with opioids, we want to give the number of days we believe are necessary, but we don't want to just give extra just in case, and that's what we did for a long time. Well, I'm going to give you 60 pills just in case you need it. And now we believe that probably isn't safe, either for that patient or potentially for other people in their household, to be giving more opioids than we think that they need. So this is helpful in helping us understand that the number of days really does matter. Dose matters. That's really important too, because all opioids aren't the same. A person on low-dose opioids does not have the same risks of adverse events, of opioid use disorder, and of overdose than a person that's on the high dose. So this helps us a little bit understand. When I talk about morphine equivalent, hydrocodone and morphine are 1-to-1, so that's really easy. The drugs that most of us are familiar with is the hydrocodone and the oxy products. So hydrocodone's easy. It's always 1-to-1 for morphine. The oxy are a little stronger. So 20 milligrams of oxy is 30 of morphine. It's a 1.5% conversion. We're going to talk a little bit about like some ceilings that the CDC has called out. One of the things that they've said is they recommend, in the exact words I can't say off the top of my head right now, but they recommend to avoid using doses greater than 90 milliequivalents for patients that have non-terminal pain or non-cancer pain. So 90 milliequivalents is either 90 milligrams of hydrocodone a day or 60 of an oxy product, just to kind of level set that for everybody that they understand. It's hard to get up to the 90 with the hydrocodone because obviously that would be a lot of pills a day. It's pretty easy with the oxy products or once you go to fentanyl or a stronger opioid because those conversion factors are just they're much stronger drugs. So what this shows us is at the low dose between 0 and 20, the risk is really minimal or negligible. When you go above 20 milligrams of morphine a day, the risk of overdose jumps up. When you go above 50 a day, the risk jumps up. And you can see there's a dramatic increase in risk of overdose once you go above 100 milligrams. This study and others like it are the rationale between people telling us you can't give more than this amount. This is the rationale between the CDC setting. It's a little bit arbitrary. To some degree, it's a line in the sand because you can see all of it is a continuum. But that's why certain Medicare, starting in 2019, no Medicare D plans will cover more than 90 milliequivalents of morphine without a very complex prior authorization process for which makes all of our heads spin because they're so time consuming. So like I said, these are the studies that explain that rationale. This is supposed to be kind of a gray, but this is another study. And what this looked at was in the state of Tennessee, they looked at within 1 year, everybody that died of a fatal opioid overdose. And what they did was they looked in their state prescription drug database, and what they determined of the people that died, over half of them, 55%, either had 3 prescribers, 3 pharmacies, or they were on that high dose of more than 100 milliequivalents. So those are things that should help us better identify high-risk patients. When we look at INSPECT, which we'll talk about because there's a new law that we have to register for INSPECT and that we have to look at INSPECT when we're prescribing a benzo or an opioid, if the patients have more than 3 prescribers, more than 3 pharmacies, or are on a high dose, that's a red flag. I can just tell you by looking at this study, that increases the risk that that patient will have an adverse outcome. It increases their risk of death. It's not perfect because you can see that 6% of the control patients who actually didn't die of an overdose, they also had these risk factors, but there's a big difference. And I guess the other thing to note is there's still 45% of patients that died of a fatal overdose, yet they weren't getting multiple drugs, they weren't going to multiple pharmacies, and they weren't on a high dose. So this isn't perfect, but it does help us a little bit understand the higher risk. There's still a lot of diversion. So diversion is when the medication we give for one person, for one indication, is used either for another indication by the same person or is used by a totally different person. Still, 50% of persons who are using prescription drugs non-medically, they're still getting them free from a friend or relative. So we still have a big problem in this country where people are, medications are being used either by someone else or for an indication other than for which it was prescribed. An example of that, though, is that if I'm given a prescription for hydrocodone or oxy after a surgery, and then I didn't use it for my surgery, but then I'm really upset the next week or I can't sleep and I use it to help me sleep, I use it because I'm stressed out, or I give it to someone else, that would be evidence of it's a non-medical, it's being used for a reason other than for which it was originally prescribed. So I think we need to just continue to make sure we educate our patients when we use opioids. This is really important. It's only taken by you. We got to make sure that patients understand safe storage and safe disposal if they don't use their medication. This is a really great study. It was published at the beginning of 2018, and it was published in JAMA. And so this is the longest study that looked at kind of the most common things we see in primary care. It looked at people with chronic back pain, hip or knee osteoarthritis that occurred daily for greater than 6 months, right? We see this like every day in our practices. This is really, really common. And then they did a double-blind randomized trial and put half the patients in an opioid group, and you can see which opioids they used here, which the stepwise treatment was, and then they put the other patients in a non-opioid group. And the patients didn't know. It was randomized and it was double-blind. And then they looked after 12 months at pain-related function. So function's really important, right? Function's kind of the new pain scale. We care more about how patients function than what this arbitrary 1 through 10 number is, because we realized after doing that on millions of patients that it wasn't that valuable. And what they found was there was no difference in pain-related function after a year. When they looked at pain intensity, they actually found a statistically significant increase in pain in the patients that were in the opioid group. When they looked at medication-related adverse events, they actually found a statistically significant increase in adverse events in patients that were in the opioid group. So I guess what this tells us, it helps me as a practitioner when I'm having those really difficult conversations with patients that are absolutely in pain. They have a reason to be in pain. You're watching them limp into your office, and as we're trying to figure out what is the best plan for those patients. And I guess what this study tells us is there's just no evidence in this study that opioids made people any better than the non-opioid therapy. So it should help us, empower us to make those decisions as we're caring for these patients. And I think we'll continue to learn more because there's more work being done to figure out what treatments work and which don't, because pain's an incredibly difficult thing for patients, and it clearly adversely affects their quality of life. So I want to share a couple other studies that I think help us make those decisions when we're seeing patients. So this was a Cochrane system review. So Cochrane studies, they're meta-analysis. They combine different studies to come up with some information that hopefully is even more value than any single study. And what they looked at was 450 different studies, and it included greater than 50,000 patients. And these were patients that had actually had a procedure or a surgery. So the 3 surgeries that were included are patients with a wisdom tooth extraction, an abdominal surgery, or a pelvic surgery. And what they looked at was the outcome was the patients that got 50% pain relief. And I'll show you, it'll be easier to understand on the next slide, but one of the things that they remark on in their conclusions is that it's interesting because there was no single medication or combination of medications that ever worked for everybody. So, we each have kind of like our neurocircuitry is like a unique fingerprint in all of us. It's different for every single person. So it really is true that the best we're ever going to get with any medication or combination of medications is probably 70% relief. So when 30% of patients come back and say, this didn't work for me, I'm still in pain, that's valid. That's true. Everybody doesn't respond. Just because it works really well for most of your patients, it's not ever going to work perfect for everybody. So I think that's a helpful concept to understand. And then in this study, when they looked at these different combinations of medications for post-op pain, the range of relief was, really there was a lot of variation. And one of the other interesting things is, across the board, these are patients that had surgery. There's still, in every study, was between 5 and 20% of patients that got nothing reported that their pain was 50% better. So it's really amazing, that mind-body connection. So I think that's interesting. So when they looked at, they actually looked at 45 different either single medications or combinations of medications. So I put just the most significant ones. And you can see that the combination of medication that worked the best to treat post-operative pain was ibuprofen and acetaminophen. 72% of patients got at least 50% pain relief. And that beat out everything. I couldn't even put Oxy on the slide because it never beat out placebo, the 5 milligrams. What I think is really fascinating is that ibuprofen 200 and acetaminophen 5 to 650 beat out Oxy 5. So we've been indoctrinated to believe that opioids are necessary for certain conditions, and they are. We need to have opioids around. But they're not necessarily the best pain treatment. So I think that's just an important thing to know when you see this. I've been telling, ever since I've read this study, for acute pain, which is different than chronic pain too, let me say that. I'm not saying this is going to work for 72% of your chronic pain patients. It's not. But for acute pain, particularly patients that have undergone a procedure, they should always have a foundation of non-opioid pain, either by itself or as an adjunct when an opioid is used. In this same study, then they looked at the time to remedication. So how long did it take in these different combinations for the patient to say, okay, I need more medication? And in this study, the ibuprofen and the acetaminophen, they still did pretty well, but it was beat out by the combination of the acetaminophen and the oxy combination. We now believe, though, that when you use different medications to treat acute pain, there's a synergy. So it's always best to use two things together, one being like the ibuprofen or the acetaminophen, particularly if you're going to use an opioid. Yes?
Both those slides are really looking only at oxycodone.
Because that's the only studies that were done. You're right.
It's really interesting because at least my perception,
Yeah.
what my teaching was, is you look at hydrocodone and you go oxycodone.
Yeah,
They're
for
more
sure.
associative
Yeah.
as opposed to
Yeah.
anesthesia.
You're right. I don't know why not one study, there was no hydrocodone data in these studies that was done. So
Plain codeine.
codeine wasn't looked at either. So you're right. That's very interesting. I think this changes our paradigm, though. We weren't taught this. People didn't let us know this. We were just taught, hey, everybody needs opioids after procedures. That's just what we do. Here's the order sets. Check the box. And I think now we're looking back to better understand what really works, what really doesn't work. So this is another Cochrane review. So kidney stones, right? We believe that, well, now that's a great justification for opioids. The Cochrane review shows there's equal effectiveness, and actually there was more nausea and vomiting with the patients that got the opioids. So patients ended up worse. Now, a lot of patients can't get NSAIDs. A lot of these patients that come in, whether they have a GI issue or they have a blood pressure issue or maybe a cardiac condition, they may not be candidates. There's a lot of patients that can't use NSAIDs. But for younger, healthy people that can use NSAIDs, this should be first-line therapy when we're treating these conditions based on this data. I want to talk about one other study that I think helps us understand how did all of these people get on persistent opioids, become chronic opioid users. So in Michigan, there's a group, they have this amazing collaborative up in Michigan called the Opioid Prescribing Engagement Network, and it's a really well-funded, it's got government, payers, insurers, the health systems all kind of collaborating together. And what they looked at, there's a lot of words on this, but they looked at 50,000 privately insured patients who underwent any one of 13 index surgeries. And you can see the surgeries are listed up here, but they kind of picked the most common ones to get the biggest numbers. They excluded anyone that had had an opioid prescribed at all within the past 12 months. They excluded anyone that had any lapse in their medical or insurance coverage because they wanted to make sure they didn't miss someone that was already using opioids. And what they looked at was 90 days past the date of the index surgery and looked at how many people then, knowing they were all opioid naive, how many people continued to fill an opioid. And they were really shocked because it was 6%. So we do a lot to make surgery safer, right? We do a lot of thromboembolic prophylaxis. We do a lot of, infection control. This is a higher risk than either one of those other things, but we've never educated patients that, hey, undergoing this minor procedure or major procedure, there's a 6% risk you're going to end up continuing on opioids in 3 months because of this. So it really was novel information, and it helped us understand that procedures, there's millions and millions of procedures done in this country, that is probably a substantial gateway to opioid use. One of the other interesting things they found was in that 6% of patients that were continued to fill opioids, it was more dependent on the attributes of the patient rather than like the severity or intensity of the surgery. And the other thing I'll say is they also excluded anyone with a wound infection that had a readmission or had to go back to surgery. So all of that was also excluded. So they found that the patients that continued they were tobacco users, which is a risk factor for any kind of substance use. They had an alcohol use disorder, substance use disorder, patients with anxiety or depression, and people with preoperative back pain. So what they did was they decided, hey, we need to look more into this. We're going to look at our most common surgery at University of Michigan. So they took lap chole. They had 200 lap choles, and they looked at what did our doctors send these patients home on after a lap chole. And it goes anywhere from like 9 pills to 120 pills, and it's scattered across. But the average number of pills at their institution was 50 hydrocodone. And they kind of, obviously different doctors use different opioids, so they had to standardized it all to hydrocodone in this study. Then they telephone followed up every one of those patients, and they got about a 50% response, and they were shocked because what they found was this was how many pills the patients took, but this is how much we were prescribing. So there's definitely a mismatch. We've kind of missed the mark on what we think patients need. And if there was no harm to missing the mark, it probably wouldn't matter. But we now know that there's harm to overprescribing opioids. So what they did was they said, okay, at our institution, University of Michigan, our new number is 15. Every patient that has a lap chole is going to go home with 15 hydrocodone, and they give a choice if you choose to use a different opioid, which I'll show you. So what they found was, after their educational intervention, the refill request went from 4% to 2%. The number of pills prescribed went from 50 to 15. This surprised them, too, because they're like, normally doctors don't actually listen when we just issue a guideline, so they were kind of like pleasantly surprised by that. And then when they telephone followed up the patients went from taking 6 hydrocodone to 4. So, you know, that's really amazing. There was an educational component because patients were better educated about using the ibuprofen and the Tylenol as a baseline and then using the opioids on top of it, which wasn't something that was necessarily, there was no standard way that was done prior to this educational output. And then the median pain score didn't change. So this is really profound. In one institution, University of Michigan, one surgery, which was the lap chole, they prescribed 7,000 less pills, and it cost nothing. And it didn't increase any real work. I mean, there was the education component, but these are the kind of changes that are happening and that we need to continue as providers in our own institutions to recognize where we've, like I said, really missed the mark. They've done a great thing. So this is all recent. So this was published, I think, in December of 2017. And since then, and this is all right off their website, they've published some amazing recommendations to be used, you know, across the country by anyone, and they're all available on this website. So what they've done is they've listed the most common surgeries, and through this big research collaborative, they've given real, discrete, specific guidance about what the right number is. And the right number, they choose much higher than what they think patients actually need, so it should cover, and this is for opioid-naive patients. So we're really trying to disseminate this kind of information to hospitals, to surgeons, to anesthesiologists. And like I said, this is the website where you can get all their information. They also have some amazing patient education information that can just be printed off. They'll even put your hospital logo on it if you send them a high-res logo. So that's pretty cool that they'll do that. So obviously, we all went into medicine because we wanted to help people. We didn't want to hurt people. So I just want to review kind of quickly what the current opioid laws are and review a couple of the best practices. So there's 4 Indiana laws for opioids. The first one that was passed in 2014 is the most extensive and cumbersome, and it can be a little more confusing. We're going to just briefly go through what that is, and that's for patients that take chronic opioids, so opioids more than 90 days. And then there's the new 7-day prescribing law that we'll talk about. This kind of, I don't think I need to say much, that's why you're all here today, I think, is to get this 2-hour CME requirement, so for your next licensure, and then there's the inspect requirement. So the chronic pain rule applies to any patient that's taking more than 60 pills a month or more than 15 milligrams of morphine. So once again, that's more than 15 milligrams of hydrocodone or more than 10 milligrams of oxy products would meet the threshold where you would have to start following these requirements for your patient if they're on that daily for at least 90 days. For tramadol, it's only if they're on a really high dose, which the FDA, it's off-label to prescribe more than 400, and I don't think it would really be helping too many people, so I'm guessing this really wouldn't trigger, hopefully, for people. And then if providers are using an extended release that's not in abuse deterrent form, for which one exists, and I think is there only one on the market, Palmer, the Zihydra? Yeah, the hydrocodone, yeah, okay. And most of you aren't using that because the one we use is with the Tylenol typically. So there's only one on the market, and it's very rarely used. Exemptions to this are patients with a terminal condition being treated with palliative care under hospice or residents of a nursing home. So a lot of people ask, what is terminal condition or palliative care? It's the definition of you, the doctor. So, you have, the discretion to make that decision, which is nice. We need discretion in trying to follow these tough things. We already went through that. So yeah, the law requires we do our own evaluation. There's so much back and forth ping-ponging with patients now, particularly because some practices are now saying, we don't treat pain or we don't prescribe opioids. There's practices that close down. There's doctors that are retiring. So one of the things is that patients come in and they say, well, I was in an accident back in 2007, and this is my regimen, and this is what I want. Well, what might have been very reasonable and rational back in 2007 is not a reasonable and rational treatment today. I mean, it may not be. So I think we have an obligation to reassess what the patient has been treated with and make sure, can we use a non-opioid medication? Is there something else we can do? Do we need to lower the dose to keep this patient safe? So we have to do our own evaluation. We can't just continue a treatment plan that somebody else had. Then I think, we have to do this risk stratification. This is, I think, a little bit of a tough concept for us. One of the things I'll say is this should give us more confidence when we do prescribe opioids if we're following this risk stratification, because it can help us feel more that we're doing things safer when we decide to do them. So we need to do a mental health evaluation. The reason for this is we know that patients that have an underlying mental health condition are at a higher risk of opioid misuse, and they're at a higher risk of developing an addiction to any controlled substance, but today we're talking about opioids. So this can be as simple as a PHQ-2, a GAD-7, a PHQ-9, just whatever simple tool you would like to use, or doesn't even, I think, have to be a tool. We have to assess their mental health. If we treat their underlying mental health condition, we're going to have a lot more success in treating their pain. So that's the reason this rule exists, is because we know that there's a real strong relationship between mental health and pain. We also have to risk stratify them for the risk of substance misuse. There are some validated tools. I think this can be more challenging. One of the easiest things we can note on the chart is smoking history. If they're an active tobacco user, they're 3 to 5 times more likely to develop an opioid use disorder with chronic opioid use. So I think smoking status can be one kind of trigger that can help you, understand they're probably at a little bit higher risk. But then the opioid risk tool, there's a bunch of tools out there. This can be either clinician or patient administered, and it's pretty simple, and it gives you a score that's interpreted as low, moderate, or high risk. So I think these are kind of simple things that can be done. These can be printed right off the internet. And then I think the other thing is, so if you identify a patient at high risk because you know they have a personal or strong family history of substance use, what do you do? Well, if they need opioids, they may still need opioids, but you may want to monitor them closer. You may want to give them a shorter supply. You may want to better educate them about the risk of this medication. So there's a lot of things you might want to do different, or you may decide, gosh, I just don't think this is safe, and so what I'm going to do is refer you to someone else because I think you're just a high-risk person, and I don't want to get you down that path of addiction, and without ensuring that I've done everything else I could to treat you in a way that might be more safe. And then there's the urine drug testing. This is probably the most controversial thing. We could spend probably a whole hour talking about this. The biggest challenge is that there's a lot of idiosyncrasies to the interpretation of the test. We do urine drug testing for 2 reasons. One, to screen for illicits, because if a patient is using illicit, if they're using methamphetamine, they already have a substance use disorder or they're using a high-risk substance, and that would make them a high-risk patient to prescribe any controlled substance to. So one is to identify a condition for which it might make it more high risk. The second thing can be for compliance testing. This, you have to be really careful. You have to make sure that the drug you're giving them is actually on the panel that you're testing. Fentanyl oftentimes is not on the panels because it's a synthetic drug. Buprenorphine may not be on your panel. Even hydrocodone and oxycodone, they don't reliably show up under the opioid panel because they're semi-synthetic. So there's a 1-800 number at the bottom of all of your test results from the labs when they come back. Those toxicologists are incredibly smart and helpful when you're struggling to interpret a test. So there's idiosyncrasies of doing this. I think it just, patients nowadays, I think they understand this as kind of just a standard expectation. We always try and give them a handout that explains your doctor is required to do all of these things to safely treat you with this medication, so that the patient knows going into it when you sign the treatment agreement that that's just part of safe care today. According to the letter of the law for Indiana, if you don't want to do a urine drug screening, you have to document all these 18 things. So it's complicated. There was an ACLU lawsuit, and so they came up with some really contorted, circuitous, meet in the middle on the law, and I think it's very confusing. But I want to just make you aware, if you don't want to do urine drug screening, you would have to kind of make sure that none of these things apply to your patient. Checking inspect is also another really important thing. I'm going to just defer on this a little bit because there's been a new inspect law that kind of overrides the requirement that was back when the 2014 law came in. And then we have to have patients sign a treatment agreement. I love treatment agreements. I know that sounds a little silly. I really think it helps a patient understand what their responsibility is, how they have to own this treatment, their part of the treatment plan. So treatment agreements, I think, can be a very useful tool. I've had patients, once they see it, say, yeah, I'm not interested in that, and that's okay too. But I think it helps both of you understand. It also gives providers a little bit of an exit strategy. If their function isn't improving, if they're unable or unwilling to come to appointments, you just can't safely give this medication. You have these requirements. So I think treatment agreements can be a really useful tool. I don't find that patients mind at all, and I use treatment agreements for anybody on a controlled substance, be it a stimulant, a benzo, or an opioid. That's not required by law. But I think it really helps set the standard for the expectation to safely give a really high-risk medication. We want to have functional goals for our patient, and these need to be documented. This will help, too, when you're trying to determine, is this medication helping my patient? I know it's high risk, but if the patient is having functional improvement, that may be a really good reason why you would want to continue it. And so, in terms of what this could look like, it could look almost like anything, but it could be, I want to work my part-time job. I want to cook 4 nights a week. I want to babysit my grandchildren. Try and have something specific that they want to achieve that they can't currently do. It's definitely much harder if you're inheriting a patient that's already on opioids, because it's really difficult, because of course everyone says, I'm better when I take it, because as soon as you don't take it because you have a physical dependence, of course you feel worse. So that's more challenging. And then you actually have to see your patients for a face-to-face visit. When hydrocodone went from a Schedule 4 to a Schedule 3 to a Schedule 2, we really should just see patients every 3 months, because technically by the law you could see them every 4 months, but then you're filling a prescription, not at a visit, and I think that's a lot of work, and I think that's a lot of liability on all of our part without any kind of ability to assess your patient and to really, the way we get compensated is through a visit today, and it's not about the compensation, but for you to take on this liability to make sure you're providing safe care, you just have to see the person in your office. So I think every 3 months for a really stable patient would be the maximum length of time. And if patients either are unwilling or unable to come in every 3 months if they're on a control, I think it's not a good idea to be prescribing that, and it's a lot of work for all of us. And then the last thing that the chronic pain rule says, if they're on greater than 60 milligrams, if you're dosing above that you need to make sure that you've had a conversation with the patient, that they understand the risks, including death, of being on those higher doses. So that kind of just summarizes the chronic pain rule. The 7-day prescribing law, I think, is pretty simple. If it's the first time you as a provider are writing a medication for a unique person, regardless of what they've been on the past, you can only write them for 7 days. That's the letter of the law. There is an exception for patients with cancer, if patients are getting medication-assisted therapy, like with buprenorphine for a substance use disorder, if the patient's in palliative care, or there's a professional judgment out. That might be you're discharging a patient from the hospital, they live in Richmond, they're not going to be able to be seen for 9 days, they had surgery, you know they're going to need more than 7 days, you could document that. So there's definitely reasons why you might want to use this professional judgment exemption, but in general, you just can't write for more than 7 days of an opioid if it's the first time you're writing for that for that patient. One of the other things that this law allows pharmacies to do partial fills, which I think is really, really helpful. The example of why I think this can be helpful is if you're giving a patient a new opioid, the patient might not want to pay or get a full 7-day supply, or you could be switching them rotating them from one opioid to another, and you might want to just say, hey, why don't you get 2 days worth and see if it works for you? Because if it causes nausea and vomiting, or if it doesn't help your pain, why fill the rest of that script? If the patient decides they need more, they can go back within 30 days, and that pharmacy is obliged to fill the remaining amount. So that's a nice option for people. Or if they can't afford it, tell them, why don't you try it and see if it works for you before you fill the rest. So I think that's a nice option. And then we already talked about this. It's a 2-hour CME requirement, and that's going to be every year. It sunsets in 2025. I guess we're hoping maybe we are around the bend by 2025 with this issue. And then the last thing here is the inspect requirement. So January 1st of 2019, every Indiana practitioner that has a CSR has to have registered for inspect. So that includes everybody, pediatricians, anybody who has a CSR. Technically, I guess there's a criminal penalty if you don't. I can't imagine that would ever be carried out. It is, yeah. So you have to apply, and then depending on when and how you access inspect depends on when this second part goes into effect. So starting right now, if you already have inspect integrated into your electronic health record, every single time you write an opioid or a benzo, you have to check inspect. Starting January 1st, 2019, whether you have integrated inspect or not, anytime you are a practitioner in an emergency department or pain management clinic, you have to check inspect every time a benzo or an opioid is written. Hospital, upon discharge, have to start in 2020. And really, all practitioners, regardless of your EMR situation, have to check inspect starting in January 2021. So there's a graduated implementation. The state of Indiana has provided funds for every EMR to integrate, so those funds are available, but that doesn't happen fast. It's like the legal and the interface issues with these IT for hospitals. It's sometimes a year or years-long process for certain places. Did you have a quick question about that?
Yes. When are urgent care required to check?
I would assume that urgent care would be you would either be now if you're integrated or 2021 because it doesn't. Yep. Urgent cares, you're definitely not an emergency department, but generally, if you don't know the patients, it may be a good idea if you're giving a benzo or opioid to check inspect. But I think by the letter of the law, it probably would be 2021 unless you get integrated inspect access prior to that time. Yeah.
The inspect data.
Yes.
I've heard different things about whether that should be included in the medical record. And arguments that it should not, or you have to sequester it in a certain area so that it's requested does not get transferred.
Yeah.
Record. So if this requirement is that you inspect on that patient, does that mean that the inspect report has to then be in the patient's chart, or you can just look at it and say, okay, inspect is keeping that and knows that I looked, so it's okay?
Yeah, that's perfectly fine. There has been an ongoing debate, can you or can you not put the information in? You can put the information in your chart now. They have discreetly said that. I think it junks up the chart way too much and it's like meaningless information. Inspect knows you checked. I would just write in your note, inspect checked inconsistent or inspect inconsistent. Yes, Palmer. Yeah. I think that's a great point. But it's kind of to the discretion of how you want to handle that. You could put it in the chart. You don't have to. Inspect will know you checked. And I always just suggest write in your note, inspect, checked, if you're not putting a copy. Yeah.
So two questions really in one is that other individuals in our practice, such as our nurses, can be delegated to check in.
Absolutely.
And number two, in my practice, I have 6 providers.
Yep.
And if the other providers are covering, can we have use one person to inspect login to check the inspection of every patient in our practice?
You know, I think that's a great question. I'm guessing that would be perfectly fine. Palmer's saying yes. Yeah, you can designate.
Because what it looks like,
It's fine.
it looks like then one practitioner, it checks everybody's patients and the other 5 don't.
As long as the patient has been checked by the practice, that would satisfy the spirit and intent of the rule. Yes. Oh, sorry, there's an exception. Yeah, right here. There is an exception if you have a pain contract. Patients on a pain contract can do it Q 90 days. But that doesn't apply to stimulants and benzos. They only say a pain contract. They don't say a contract, it says pain. So I think for benzos, if you are giving the patient refills at the time you see them, you're fine, because on the date it was written, you checked inspect. But if you're calling in scripts every month or every 2 weeks or whatever, yeah, you would have to check inspect all those dates. This doesn't say anything about a stimulant. I'm sorry. This is for opioids or benzos. You know what? I want to just finish my last slides and save questions for the end because Palmer actually is a better speaker and probably has more interesting stuff to say than I had. So I don't want you to miss out on that. And then we'll stay around and answer questions for as long as anybody has any when we're done. I want to just call your attention. The FDA has issued a black box warning against co-prescribing benzos and opioids. The reason is this is the most common combination found in patients that overdose. So we know polypharmacy is a big deal. I think this is tough. According to Medicare data, 20% of all patients taking chronic opioids are being co-prescribed a benzo. That's like millions of people, so that's a lot of people. We see it all the time. It doesn't mean I want you to cut people off. That's not safe or reasonable, particularly for benzos or for opioids. We have to start having these conversations now. We're going to be penalized, I think, by health plans. I don't think this is going to be covered in the future. So I think we have to start having those conversations. The pain clinics, when they go to a pain clinic, they're told at the first visit, you pick which one helps you more, but they strictly prohibit co-prescribing of benzos and opioids, even if someone else is writing the other medications. So we need to do a better job. We have to let our patients know going forward this just isn't something we can safely do. One of the things I say is just ethically and legally this just isn't something I can safely treat you with today or in the future. Canada is relabeling all their opioids. It's going to be considered off-label to prescribe any opioid above 90 MME starting in January. This will be printed on every single opioid that's dispensed, and acute pain in that country is going to be limited to 3 days. Just be really careful. Universal precautions when we give opioids. Patients that are under 25, that's before our frontal lobe doesn't mature until 24. So any exposure to an addictive substance or that has abuse potential, it can rewire that neurocircuitry. It can put them at a higher risk of misuse or addiction. And the ages of 18 to 24, that's the most likely age group to misuse controlled substances. That's been that way since the beginning of time. So be aware of younger people, even up to the age of 25. We definitely want to avoid opioids in patients that use benzos, that use alcohol, that use illicits. And then we just want to be really aware of untreated mental health issues because that really increases risks to patients. And then patients with respiratory problems, particularly sleep apnea, they're already desaturating. And then the opioid causes a central respiratory depression. And that's why a lot of times patients that are just getting medications from one doctor for one opioid are overdosing because they have underlying sleep issues. And a lot of times one of the things that we're recognizing is that as patients age, they develop sleep apnea. They develop obesity. So just because they've been on this opioid and it's been fine all these years, once they start having sleep apnea, that completely changes the risk profile, and you may need to make a change in their management. Make sure for safe disposal, there's a lot of different ways you can do it, but the easiest is just tell people, take your opioids, mix it with kitty litter or coffee grounds, and throw it in the trash. We don't recommend putting it in the toilet. They definitely can go to these safe disposal places, but if you put it in the water system, it ends up in our drinking water, so we definitely want to avoid that. And then I think this is really tough. I hope I've given you a little bit of information. I want to turn it over to Palmer. That concludes my portion. I will be here afterwards, and I'm happy to answer any unanswered questions. Thank you.